We're not?
No, we're testing.
Dr. Lipsedge, I'm very sorry for the delay. I hope that the difficulty has now been resolved. What I propose to do is that we shall sit for an hour until 11:45. We'll take a 15-minute break, and then we'll sit for an hour from 12 till 1. But that's subject, if you want another break during that time, just let us know. So I'll now hand you over to Miss Graham again. Miss Graham.
Thank you. Good morning again, Dr. Lipsedge.
Yeah. Good morning, Miss Graham.
Good morning. Before the break, you said that you were Dr. Maurice Lipsedge. Is that correct?
That's correct. Yeah.
And you were 86 years of age.
That's right.
And we were just going to have a discussion about your career. You've been a consultant psychiatrist.
Yes.
Now, you've provided the inquiry with a detailed statement, haven't you?
Yes, that's correct.
And that was taken on the 22nd and the 30th of December last year by a member of the inquiry team.
Yes. I'm not sure of the dates, but...
Don't worry about the dates.
Yeah.
I don't need you to confirm that. But you had an opportunity to consider your statement, and you then signed it for us and sent it back to the inquiry. Is that right?
That's correct.
And just for my purposes, you know that you've stated that the contents of your statement are true. That's correct, isn't it? And
correct.
You understand, Doctor, that the statement may be part of the evidence for the inquiry, that the chair will be able to read it in detail.
Yes.
And you also know that it's going to be published on our website so that others can also read the whole contents of your statement.
Yes, I understand.
Right. And it was on the basis of that understanding that you signed it and sent it back to the inquiry.
That's correct.
Excellent. And in addition, you've also sent us some articles and documents which are referred to in your statement that the chair will have available to him to look at.
Yes.
Thank you. So should the chair understand that in addition to the evidence that you give us today, he should also have regard to the statement and the documents that are referred to in your statement and that you've referred to? Lovely. Thank you.
That's correct.
Thank you very much. So for the members of the public that might be listening, Dr. Lipsedge, I understand, I'd like to talk a little about your career. And I understand that you have been a consultant you were a consultant since 1974 in general adult psychiatry.
That's correct.
And you briefly talked about working at different hospitals, and you retired in 2001, is that correct?
I retired from the National Health Service then. I was 65.
Right. And so,
I continued to work.
And as I understand it, you've continued to work doing medical legal work.
Medical legal work and working in occupational medicine, occupational psychiatry.
And how long did you continue working after your retirement from the NHS?
Oh, until very recently. The last work I did of any significance, I think, was giving evidence at the inquest into the death of Leon Briggs. That was about 2 years ago.
Thank you.
But I've I've continued to teach since then. I'm an emeritus consultant at the Maudsley Hospital, and I'm what's called a visiting consultant at a medium secure psychiatric unit. And I've continued to do that until the present. I do that work remotely, and I attend the ward round of the consultant in charge, Dr. Raj Mohan.
Thank you. And you've also been called upon to assist in relation to work that's being done in relation to excited delirium and acute behavioural disorder. Is that correct?
That's correct. That was a committee or a subcommittee set up by the Royal College of Psychiatrists to look into the concept and practice associated with excited delirium and acute behavioural disturbance.
And am I correct in saying that acute behavioural disturbance is sometimes known as ABD?
That's correct.
And you've also written articles about the topic?
Yes, the two articles really are, the first one was a critique of the concept of excited delirium, and that appeared in a journal called Medicine, Science and the Law in 2016. And then more recently, together with Terry McGuinness, a barrister, and he was the senior author, with Terry McGuinness, we wrote another critique of excited delirium and explained its historical development, mainly within the United States.
And was that published last year?
Oh, yes, 2022 in a journal called Psychological Medicine.
And are those journals respected journals in your field, medicine, science and law? And the...
Yes. And psychological medicine. And yes, they're highly respected journals.
Thank you. And as I look at your statement, and I don't need you to look at it, but you've given the chair some detailed information about inquests and cases that you've been involved in, where you've been asked to provide expert opinion and evidence in relation to that.
That's correct, and that goes back a long time, about 40 years. I'd be invited to give evidence on behalf of the families of men who'd died in custody, the charity inquest and the legal firm Butt Murphy would be involved in inviting me to give a psychiatric opinion in those cases.
Thank you.
And
you've detailed those in your inquiry statement for the chair to consider?
Yes, I have.
Thank you. And a number of these, did they involve the deaths of young black men?
Yes, they were all young black men.
And
one of them, David Bennett, died in a National Health Service medium secure hospital. The others died in police custody.
And some have involved restraint in police custody by police officers?
Yes, they all involved restraint, including the death of David Bennett in hospital.
Right.
He was restrained by nurses, not by the police.
And was one of them called Roger Sylvester?
Roger Sylvester, yes.
And that was an inquest in 2003, as I understand.
That's correct. If I can add, the first one was Mr. Winston Rose, who was mentally ill, was detained under Section 136 of the English Mental Health Act and was being transported to a police station in a Bedford van. And he was being transported in the well of the van with the feet of the police officers sort of containing him while he was on the floor. And to my mind, the most important one from the point of view of excited delirium was Ibrahim Sy. If I could, Ms. Graham, if I could say a few words about that.
Please do, yes.
Incident and about the inquest. Ibrahim Sy was an asylum seeker from the Gambia, and he was a young man, I think in his 30s. He had an undoubted episode of mental illness, and a previous history of mental illness. And he became very disturbed, and his wife was very frightened of him and had to escape from their home. The police were called, but also his best friend, Gambia, was called, and the best friend was able to calm him down, and he was transported to Ilford police station in a reasonably calm state. When they got to the yard of the police station, the friend was not allowed to accompany him into the station. And at that point, Mr. Sy became very suspicious and frightened and tried to escape. And he was restrained by a number of officers. He was sprayed with CS gas, but it's the physical restraint that was significant in that case. And he died in custody. Now, the reason I'm emphasizing that particular case is that at the inquest, the psychiatrist for the police, Dr. Kennedy, he said that he believed that Mr. Sy died from what he called Bell's mania. Now, the literature on excited delirium often invokes Bell's mania as a sort of historical predecessor of the phenomenon. I think incorrectly. Very briefly, Luther Bell was a psychiatrist at a hospital in Massachusetts in the United States in the 1840s. And he described a number of patients who were extremely excited and who were also delirious. And they all died, but they died after many days, up to 30 days of excitement. And I think the shortest length of time before death was something like 10 days. So Mr. Sy had been disturbed for a matter of hours. So to ascribe his death to Bell's mania was incorrect, because Bell's mania, as I just said, described death after 10 days, and this was a matter of several hours in Mr. Sy's case. And that provoked my interest in the possible misuse of psychiatric terms in the context of deaths in custody, where it seemed to be claimed that the primary cause of death was a psychiatric disorder rather than restraint or other factors.
And I think you explained to the chair in your statement that at the inquest for Mr. Sy, the suggestion that the cause of death was a psychiatric disorder was not accepted by the coroner, and the jury returned a verdict of unlawful killing. Is that correct?
That's correct. That is correct.
Thank you. And in addition, I think we can see in your statement that you mention and provide the chair with details regarding Leon Briggs, who you've already mentioned. And
Yes.
for those who wish to look at it, this is SBPI 00298. That's a number, you don't need to worry yourself with that, it's just for anyone who wants to look at it. And we see that you've given some information to the chair about the Leon Briggs inquest at paragraph 5 of your statement.
Yes. And I felt
I'm
that
interested
the case
in
of-
this and the relevance it may have to the circumstances that we're looking at in this inquiry.
Yes. The relevance for me was that this was another young black man who had been behaving in a public place in a very bizarre way. He did not have a weapon. He did not harm anybody, but he was jumping in front of cars, leaping on cars, taking risks with his own life, and was clearly very disturbed. And a member of the public called the emergency services, and she actually emphasized that the individual needed both an ambulance and help from the police. Now, the first available police officers were a team of armed officers, and they, without attempting to have a conversation with Mr. Briggs, restrained him and restrained him in a highly unsatisfactory way. I must add that the cause of the obvious behavioral disturbance in Mr. Briggs' case was the fact that he'd taken large amounts of amphetamine.
Now, if we can have on the screen the next page of the statement, please. So, just so that people can follow this, Dr. Lipsedge, you use the
Yes.
word de-escalation and say there was no attempt at de-escalation. And then in paragraph
Yes.
6 of your statement, you talk about if it had been a sort of old-fashioned policeman on the beat. Can you give us a little bit more detail about that?
Yes. Mr. Briggs was clearly disturbed, but he hadn't harmed anybody, he hadn't attempted to harm anybody, he certainly wasn't armed. He appeared bewildered and very frightened. And he had been in a shop where the shopkeeper recognized him. They hadn't had a satisfactory conversation, but it was clear that it was possible to engage in some sort of dialogue with him. And rather than restrain him physically, the first step, in my opinion, and I think the coroner agreed with this, the first step should have been a verbal de-escalation. That's to say, an attempt to approach him in a calm, measured way, to reassure him, to introduce themselves, to explain why they were there, and to try and sit down with him, to reassure him rather than to be very authoritarian with him.
And I think in paragraph 6 of your statement, you describe it as something, let's sit down and have a cup of tea in this cafe.
Yes, that's right. I think I felt at the time that if this hadn't been an armed police squad, if it had been an old-fashioned sort of police officer who'd arrived, who'd been the first on the scene, or a couple of officers, they would have been less forceful and more inclined to try and have a chat with Mr. Briggs, and the outcome could well have been different.
And then in paragraph 8 of your statement, you say the jury criticised the restraint by the police, which was mostly in the prone position, with the application of inappropriate use of force. They also criticised a failure to recognise Mr. Briggs as a medical emergency, inadequate assessments, and a failure to monitor him. And these failures contributed to his death.
That's correct. And the ambulance service, the ambulance people were present, were witnessing what was going on, but they did not get involved, and they were criticized because they said they hadn't been trained how to help in these situations.
And this is, sorry.
There was a lack of monitoring of a person who was by then in a physically distressed state as a result of the combination of restraint and struggling against restraint.
Sorry, there was some coughing there and I didn't hear your answer. You said there was a combination of restraint and
struggling against restraint.
Thank you. And you gave evidence... Sorry, I interrupted there. No, please finish your answer.
Well, this might be an opportunity to explain what happens in these situations where an individual who's being restrained, especially if they're paranoid, i.e. have a mental state in which they believe that they're being persecuted or people wish to harm them, then when they're restrained, they'll struggle against the restraint because they believe that they're going to be harmed even worse. And the struggle, there's a vicious circle of struggling and fear on the part of the restrained person. And the struggle provokes the restraining officers to exert even more pressure. So from the patient's point of view, it's a life and death struggle. From the restraining officer's point of view, it's a sign of lack of cooperation.
Right. Thank you. And you gave evidence at the inquest in relation to the death of Leon Briggs, and that was in 2021.
That's correct.
Thank you. I'd like to move on now to your involvement with the death of Mr. Bayo. And
yes,
I'm not asking you to remember exact dates, but I'll read out some things that you've said in your statement, and you can hopefully confirm the general dates. So you had a letter of, you were instructed by PERC originally. And they sent you a letter of instruction in November 2015. Is that correct?
That's correct.
Had you had much involvement with them prior to the November of that year?
With Perk,
With Perk?
no, but I had done a couple of reports for the English equivalent, which was then called the
IOPC?
Independent. Even then it had a different name, Independent Police Complaints Commission.
Right. So
And
for people who are in the room, that letter of instruction is COPFS 06007. And we'll see this is a letter dated the 19th of November 2015. And on page 2, we can see that Perk asked you to prepare an expert witness report on their behalf. And they were interested in your views on the potential impact of the drugs identified on the behaviour of Mr. Bayo, and as that had been described by police and civilian witnesses.
That's correct.
And then they had also initially asked you about views on behavioural science and the mindset of the officers as a group, but I think you laterally said that was not within your area of expertise.
That's correct. I felt that that was more the domain of the social psychologist.
Thank you. And you subsequently prepared a report for Perk, which we have as COPFS 00130, and you sent that to them on the following year, 18th of January 2016.
That's correct.
And as part of preparing your report, did you consider a number of documents and information that Perk had sent you?
Yes. And a video.
Was that CCTV footage?
Yes, that must have been CCTV. Showing Mr. Bayo mainly running in the street. I didn't see him being restrained in the video.
We've seen CCTV images, and I don't plan to play them today, but we've seen some images of Mr. Bayo walking on a journey towards Hayfield Road and actually in Hayfield Road. And is that the images that you saw? Thank you.
That's right. And the striking thing was that he seemed to be wandering almost aimlessly. He seemed to be disorientated. He took no care about his personal safety in terms of risk of being knocked down by cars and so on.
And
he seemed bewildered.
And I think in your report you mention seeing him near a roundabout at Hayfield Road, and I think you used the word confused.
That's right.
And you were also sent civilian witness statements and police statements, medical reports, and post-mortem information as well. Is that right?
Yes.
And you considered all of that before you prepared your report for the Perk?
Yeah, I did.
Thank you. And as part of your report, which I can see is you've summarised a lot of information that you were sent and highlighted what you considered significant or relevant for your purposes.
Yes.
Thank you. And you talk about the nature of, we've heard evidence, Dr. Lipsedge, of the drugs which were found in samples that were analysed as
Yes.
part of the assessment of the pathology. And you've mentioned in your report the impact of a drug called MDMA that we've heard is commonly called ecstasy.
That's correct.
Would you be able to give the chair just a small summary of the impact that drug has on a person's state of mind?
Well, normally ecstasy, MDMA, is a stimulant. It's not generally associated with severely adverse psychiatric effects. There are some reports of it causing paranoia, but that's unusual. The more general impact in terms of the way an individual who's taken ecstasy would relate to other people is actually they may feel better disposed than usual to other people. It's a drug that's usually taken in nightclubs, and people take it partly because it actually is thought to generate a feeling of non-aggression and of friendliness rather than paranoia.
Thank you.
However, there are some reports, but this is rare, of it having the opposite effect.
And I think on page 16 of your report, you say it's relatively rare, but it can be associated with acute paranoid psychosis.
Yes, and that's what I meant when I said that's a rare side effect.
And that's towards the bottom of page 16. There, thank you. Keep going. It's on the screen now. And can you explain to the chair how someone would appear if they are suffering from acute paranoid psychosis?
Yeah, they would appear very frightened and suspicious, and very difficult to engage and to reassure, because they believe that either specific people or people in general or some external agency or a combination of those are plotting to harm them. And so they may take defensive action, or they, an example might be as they come into a consulting room, they might unscrew the light fitting because they believe that there's some electronic device which is bugging them. So that's sort of highly suspicious behavior. They might accuse people who they don't know of wishing to harm them, plotting against them, organizing a conspiracy against them. It is a very difficult state to deal with, but it's very important to listen to a person who's in that frame of mind, not necessarily to agree with them, but to make sure that they know they're being listened to.
And can
rather
that help?
Than being yes.
What difference does listening make to a person in that state of mind?
I think it shows it reassures the individual that they're being taken seriously and that they're not being dismissed out of hand. It's quite often possible to establish some sort of rapport with people who are paranoid, because the paranoia might just be focused on one particular area of suspicion, and in all other aspects the person may be functioning normally and have otherwise normal beliefs. So the doctor, nurse, ambulance people, indeed the police, should try to work with the non-suspicious aspect of a person's mental state, if they possibly can. It's not always possible.
And how does that exercise of building rapport and listening help someone deal with a person who is in a paranoid state of mind?
It's a question of showing the individual that you're listening, that you're taking them seriously, that you're prepared to consider their belief, what their belief is. Doesn't mean you necessarily have to agree with them that there's an awful conspiracy mobilized against them, but hearing their version and rather than refusing to listen is reassuring to the patient.
And from a psychiatric...
allows you to start. Yeah, listening allows you to, and possibly giving feedback. So saying to the person who's unscrewing the light fitting, looking for a bug, saying, I can see that you're afraid that somebody is monitoring your movements or your behavior, your speech, and I can understand that's the reason you're actually carrying a screwdriver to unscrew the light fittings and so on. And then you'd add, of course, I understand that must be very frightening for you. And then you try and reassure the individual by perhaps asking them about other aspects of their life, which might be perfectly normal. And you can engage in a conversation on a neutral subject and try to diffuse the fear and indeed the terror.
And so are you talking about an acknowledgement of the way the person's feeling,
yes,
but not necessarily an agreement or an acceptance that that's valid?
That's it, yes. Ms. Graham, you put that very well. Acknowledgement rather than agreement.
Right. And from your perspective, Doctor, is there a time constraint or limits to the time that can be taken to build that rapport and engage with that person?
What I teach medical students is, in a situation like that, you have to pretend that you've got unlimited time. Now, of course, you haven't got unlimited time, but you have to give the patient the impression that you're able to listen to them and that you're not in a hurry. My experience is that people feel, to use a local term, disrespected if you show that you're in a hurry or if you've got a deadline. Now, of course, for professional reasons, you might well be in a hurry, but you have to convey the feeling that you have unlimited time to spend in discussion with the patient.
And it probably goes without saying that if circumstances change or the person becomes a danger to themselves or others, then that might be a reason to limit that time that you're engaging with the person, presumably.
Of course. What I should have said right at the beginning is if a person is armed with a gun or with a knife or some other weapon, what I've been describing is completely unrealistic, and safety takes top priority. But if during the dialogue situation changes and the patient tries to attack you or somebody in the room, then you've got no alternative but to use physical restraint.
Thank you. And then moving on to another drug that you've mentioned in your report, you mentioned alpha PVP, and we've
Yes.
heard that that's a synthetic cathinone.
Yes. Now, that's a very powerful stimulant. It's a synthetic drug which has been manufactured since probably around about 2000. And it's like a very, very potent form of amphetamine. And we know that amphetamine has the potential to cause extreme paranoia fairly quickly. That's to say, within 20 minutes, 45 minutes, it acts quickly. It doesn't do that to everybody, but in a person who happens to be susceptible, then there can be a paranoid reaction which can be extreme. And that's what I think happened to Mr. Bayo.
And I think we've certainly heard evidence that he had alpha PVP in his system. Now, I think you say at the bottom of page 14 that the effects of this can last for 3 to 5 hours.
Yes.
Is that a sort of reasonable range or estimate, or is that?
No, that seems correct to me. And the onset, as I said, is fairly rapid, could be within 20, 40 minutes.
Thank you. And if we look at page 15, you talk in your report about some common adverse psychiatric and neurological effects, and you mention, if we can stop there, agitation, paranoia, hallucinations, seizures, the release of noradrenaline, which causes rapid heartbeat and raised blood pressure. And
yes,
can you help the chair understand how someone having taken this drug would appear and what their state of mind would be?
The state of mind, certainly in this case, and as described in the literature on they're called novel or new psychoactive drugs, and this is a good example. The street name was bath salts. The adverse effect is, the adverse psychiatric effect, as I mentioned, is suspicion and moving into paranoia, intense fear that other people want to harm you. And in Mr. Bayo's case, it's clear that there was a progression from suspecting that his friends were having a conversation about another person who wasn't present. Mr. Bayo thought that they were talking about him. And then the situation escalated so that he began to think that his friends were actually against him, and that culminated in what I thought was a very serious attack indeed on his best friend, best friend felt his own life was in danger given the ferocity of the assault.
So you mention on page 13 of your report that you've considered the statements of his friends
Yes.
who noticed, if I may summarise, a change in his normal behaviour. He seemed to be acting out of character.
Yes.
And I think one of the police officers who gave evidence said he understood that Mr. Bayo had felt disrespected in the home of a friend and had left quite suddenly.
Yes. That's absolutely.
And you've talked about the development of these adverse psychiatric reactions. I think in your report you mention the first sort of stage of psychosis. Can you explain to the chair how psychosis develops?
Well, I use the term ideas of reference. That's where a person suspects that either other people or, for example, television are referring specifically to that individual, either giving them a special message, but very often saying something hostile and negative and threatening. And so this then evolves into, as in this case, challenging his friend. He accused one of his friends of being in the CID, and he became increasingly suspicious. And it was clear that he felt they wished to harm him, which obviously wasn't the case. I think it's important.
Sorry, I
I'm sorry.
interrupted there.
It's important to mention that his friends reported that there'd been similar but less severe episodes in the past. And that wasn't altogether surprising, because we know that one can start with a relatively minor reaction, then as time goes on with repeated usage of a drug like this, the brain becomes sensitized, and the individual becomes more vulnerable and more likely to have a more extreme reaction.
And then I think, returning to page 15, you do talk about psychiatric effects can include severe panic attacks, extreme agitation, paranoia, hallucinations, and violent behavior in connection with
correct.
this drug.
Yes, that's right.
And in terms of psychosis, would that be at the more extreme level of behavior? You've described how
Yes.
it starts off as paranoia.
Yes. Well, it starts off with paranoia, then paranoia would be on a spectrum of mild to very severe, and simply means, in this context, it means an unwarranted suspicion that people are against you, hostile to you, wish to harm you.
Thank you. And then finally, you also mention the existence of steroids in his system,
Yeah.
which were noted. We heard evidence about that this week. And you've talked on page 14 of your report about there being a strong temporal relationship between steroids and violent outbursts or violence. And that's at the top of page 14. Even where people have no previous history of violent behaviour.
Yes. Have to emphasize that we're talking about so-called bodybuilding steroids as opposed to therapeutic type of steroids.
Of course. Sorry.
Now, these anabolic or bodybuilding steroids, there have been quite a lot of reports of these bodybuilding drugs causing aggressive behavior. However, more recent research suggests that the earlier papers tended to overlook the possibility that the bodybuilder was taking stimulant drugs at the same time. That's to say, drugs like amphetamine. And amphetamine in large doses can cause violence, aggression, hostility, paranoia, and so on. So the earlier reports didn't disentangle the possibility that it wasn't just the steroids, the bodybuilding steroids, but it could have been other drugs that were being taken at the same time and which were being commonly used by bodybuilders.
And I think if we look at your opinion in your report, the final paragraph on page 9, you take the view that, or you took the view that the steroids were unlikely to have contributed significantly to the paranoid and violent behaviour, and it was better accounted for by the other elements in his system.
Yes, especially the alpha PVP.
The alpha PVP particularly. And I'd like to just go over your opinion with you, if I may. It's page 18 of your report.
Yes.
And you talk about this being a retrospective psychiatric diagnosis. Is this the part of your report where you brought together all you'd learned from the documents and information you'd been sent and your consideration of the CCTV footage, and then expressed your view to PERC?
That's correct.
And I think you talked about the rapid changes in Mr. Bayo's mental state and behaviour from apparent normality were consistent with psychostimulant intoxication. And
that's correct.
Right. And can you explain to the Chair what psychostimulant intoxication is?
Yes. Well, the psychostimulants are drugs like amphetamine, like cocaine, like the group of drugs called cathinoid, in which they have a sort of excitatory effect on the brain, on the nervous system, and there's a release of dopamine, which is the pleasure-seeking component. There's also a release of adrenaline and noradrenaline, which can raise, very commonly, raise the heart rate, raise blood pressure, and cause strain on the heart, make the heart vulnerable, and if the heart is deprived of oxygen, which can happen during restraint, then there's a risk of cardiac arrest due to a disturbance of the rhythm of the heart.
And we've heard that alpha PVP of itself could result in a fatality.
Yes.
And can I be clear, is psychostimulant intoxication a descriptive term, or is it a recognised psychiatric disorder?
Oh, it's recognized psychiatric disorder, and it's been in the diagnostic manuals. That's the International Classification of Diseases, and then the American system, which is the Diagnostic and Statistical Manual. It's been in successive editions of those two manuals for several editions over a couple of generations, I guess.
Thank you.
So it's a well-recognized category.
Thank you. And then you describe in your report his condition evolved rapidly in a pattern that is well recognized in descriptions of drug-induced intoxication. Is that the same, more general?
That's the same. Yeah. That's correct.
And you've talked about psychosis caused by these stimulant drugs evolving from a period of increasing restlessness, suspiciousness, and ideas of reference, which you've mentioned earlier, and the patient misinterprets everyday events or conversations in a delusional fashion, believing that people are plotting against him or are about to attack him, and the patient may
That's,
act on these beliefs with extremely violent behaviour.
yes, yes, exactly.
And then I think in your opinion you say, although some pathologists and toxicologists use the term excited delirium to describe this clinical picture, most British psychiatrists prefer to use the term psychostimulant psychosis when there is toxicological evidence of the use of, and you list a number of drugs, including cathinones.
That's correct.
And we've heard evidence to the inquiry that MDMA and alpha PVP are indeed cathinones.
I'm not sure that
Oh, actually,
ecstasy, cathinone.
Sorry, I'm confused. It's alpha PVP that is a cathinone.
Yes.
Sorry, that was my mistake. And then you talk about the previous use and sensitization. Was this the examples that you obtained from the friends who'd spoken about maybe previous experiences he'd had?
Yes, exactly.
Can you explain to us what sensitization is?
In a way, it's the opposite of habituation. So, if I can use an analogy with alcohol, over the years, a person may become tolerant to the intoxicating effects of alcohol so that they're able to drink increasing amounts with less undesirable effect. Now, sensitization is the opposite to that. So, with successive exposure to the to alpha PVP, the brain reacts increasingly in a negative way, with increasing risk of the intoxication that I referred to, an increasing risk of paranoia, suspicion, and violence.
Thank you. I'm conscious of the time, but I've only one last question in relation to your report, if I may ask that.
Yeah.
You'd said when you prepared this report that in addition to the drugs, that he appeared, from the information you were sent, that he drunk a significant amount of alcohol shortly before he began to express paranoid ideas. And you commented on the connection with alcohol. I understood you were subsequently advised that that was not, although eyewitnesses had spoken to him drinking alcohol, it didn't prove to be the case from the results obtained in terms of the pathologists' investigations.
Yeah.
But did that make any difference at all to your overall view about the psychostimulant intoxication?
No. I felt that I accepted the account from his friends that he'd drunk alcohol, and my view was, if that was the case, and I had no reason to doubt that it was the case until I saw the toxicologist's report. If that was the case, it would just make the reaction to alpha PVP worse.
All right.
It would exaggerate the negative effects.
All right. Thank you very much.
Dr. Lipsedge, we'll take a 15-minute break now and we'll then carry on to lunchtime.
Yes, sir.
Yes, Miss Graham.
Thank you very much. Hello. Can you still hear me, Dr. Lipsedge? No. Dr. Lipsedge, can you hear me? Dr. Lipsedge, do you hear me now? Doctor? Hello? Can you see me? Dr. No. Maybe give it a moment.
Yeah, we'll just give it a minute or so to see. It's resolved. Dr. Lipsedge?
Okay.
I think that's it now. Are you hearing me now, Dr. Lipsedge?
I'm not sure he can hear or see me.
I think
at the
that's right.
moment,
I think so. We'll just
unfortunately.
try it again briefly and see if we can resolve it. Now, Dr. Lipsedge, I think we're back with you again. Can you hear
Yes, sir.
me?
Yes, I can
Okay,
hear you.
that's fine. Miss Graham.
Thank you. Hello, Dr. Lipsedge. Are you able to hear me?
Yes, I can hear you clearly.
Oh, thank you. I was going to move on. You've mentioned 2 articles that you wrote, and I'd like to look at both of them. Can we look first
Yes.
of all at the 2015 article that you mentioned? So that's
Yes,
by you alone, called Excited Delirium, a Psychiatric Review. And it was published in the Medicine, Science and the Law publication, first published
Yeah.
on the 8th of June 2015. So just over a month
Yes.
after Mr. Bayo's death. And
yes.
the chair will be able to read this article in detail at a later date, but there's 1 or 2 things I'd like to ask you about, if I may. And I think you've
Yeah.
already said that this was an article in which you mentioned the term excited delirium being used to explain sudden and unexpected restraint-related deaths. Was this the first publication in the UK, or had it been mentioned in the UK prior to that?
As far as I know, this was the first comprehensive review published in this country.
Right. And we'll come on to that again, but I see on page 1, if we look further down on our copy, I can see that you've raised that there is an important divergence of understanding of the term delirium. I think you touched on
Yes.
that earlier this morning, and you mentioned the development of that divergence over the past 30 years or so, since Vetley and Fishbane used the term excited delirium specifically to explain deaths during or after restraint in American recreational cocaine users. And was that when the term began to differ
Yes.
in relation to delirium? Can you begin by explaining what delirium is from a psychiatric perspective?
Yes. Delirium is a term that's used to describe a state which is often accompanied by a high temperature, in which a person is confused, agitated, disorientated, fearful, and generally you come across it in hospital patients, often elderly people, or post-operatively. It's pretty common and only lasts a day or 2 in otherwise relatively fit people. So it's a condition that you'd see in the hospital. You might see it in homes for terminally ill people, but generally in an acute hospital setting, either post-operatively or as a feature of, say, kidney failure, liver failure, sometimes cardiac failure, sometimes respiratory failure. So it's, or post-head injury, or during an infection, acute infection of the brain. So it's very well recognized within medicine, with the features that I've already mentioned: confusion, agitation, disorientation. Another common form would be what's called delirium tremens, which occurs during acute withdrawal from alcohol. That would come under the same heading.
Thank you. And on page 2 of this report, in the right-hand column, towards the latter half of that page, I see that you say, for psychiatrists, delirium by definition is the neuropsychiatric manifestation of either intoxication by or withdrawal from a psychoactive substance, or of one or more underlying serious and potentially fatal medical conditions, which might be infective, inflammatory, metabolic, vascular, neoplastic, or traumatic. And then you also see some symptoms of delirium overlap with the symptoms of primary psychiatric disorders. And then in the last paragraph there, you say from a psychiatric perspective, if a patient dies during a bout of delirium, there will be autopsy evidence to confirm the underlying organic cause, for example, septicemia. Thus, the cause of the patient's death is not their psychiatric disorder or their agitated behaviour, but a grave underlying medical condition, which will be revealed at autopsy. We move on to the next page. In the absence of an underlying physical cause for an acute behavioural disturbance, the use of the term delirium in this way is self-contradictory. And so it seems
Yes.
that you, as a psychiatrist, am I correct in saying you understand delirium to have a sort of medical, to be a medical condition with medical or physical signs that may be available and observable at a post-mortem?
Absolutely.
And to that extent,
That's
is it different then from the term excited delirium?
Yes, because in excited delirium, by definition, excited delirium, as the term was being developed in the United States, there was no autopsy evidence of a physical, an organic cause for the person's death.
So the chair should not be confused by the reference to the term delirium. There's two separate things altogether.
They're separate when it comes to describing a cause of death. With delirium, physicians, psychiatrists, we would expect if the patient dies, the pathologists at autopsy would find the cause for the delirium and the cause of death. So, for example, septicemia.
Thank you.
For example, meningitis.
Right.
And my quarrel with the use of the term delirium in the context of the American term excited delirium was there was no evidence of an organic cause for either the delirium or for the death.
Thank you. And then on page 3 of your report, there's a section entitled Acute Behavioural Disturbance and the Risk of Fatal Outcome. And you say, in general, severely disturbed behaviour, which requires restraint, may have a medical cause, a primary psychiatric etiology, or be due to recreational drug use. Medical causes include those numerous organic conditions which cause delirium, as defined in both DSM-4 and DSM-5, as well as in ICD-10 and in standard medical and psychiatric textbooks. There is an obvious mortality associated with the underlying organic condition, and neuroleptic malignant syndrome would be included in this section. Most antipsychotic drugs can also be associated with sudden, unexplained and unexpected deaths. And
Yes.
again, is it correct to say then that delirium is a recognised psychiatric condition that appears in DSM-4 and 5 and ICD, you've said 10 in this report, when it's now ICD-11, it's a new version now. And is that recognised within those classifications?
Absolutely.
Right. And my understanding is that DSM-4 was published in 1994 and 5 was published in 2013. And ICD-10 was published in 1992 and 11 was published in January of last year, 2022.
Correct. Yes.
And ICD-10 is a globally used diagnostic tool, which is used for clinical purposes, and it's maintained by the World Health Organization. Is that correct?
That's correct. Yes.
And DSM, the Diagnostic Statistical Manual, is a diagnostic tool published by the American Psychiatric Association and is the standard classification of mental disorders used by mental health professionals in the US.
That's correct.
Thank you. They're both well known in the Scottish courts also, Dr. Lipsedge.
Yeah. Yes.
And then you go on in this report to make clear on page 4 that excited delirium does not appear as a separate diagnostic category. If we could just move down that page, please. So ED does not appear as a separate diagnostic category in DSM-4 or 5 or ICD-10. The term delirium in the American forensic pathology literature is not used in the restrictive DSM or ICD sense of acute behavioural disorder attributed to an underlying organic condition. So in this section of your 2015 article, is it clear that as a concept, excited delirium does not appear in either of the classification tools, the DSM or ICD-10, which are used around the world?
If we look at ICD-10, which covers, or ICD in general, the publication by the World Health Organization, they cover all recognized diseases, and they would include delirium, but in the sense that we've discussed just now, i.e., where delirium is an agitated, confused state of a patient who has an underlying medical cause for their agitation and disorientation. So it's used in a medical context.
Right. Excited delirium does not appear in either of those publications as a separate diagnostic category.
Well, delirium appears in ICD, and delirium is described as either stuporose or its opposite, which is agitated or excited. But the context, the explanation is very important. It's always attached to the presence of an underlying physical cause.
Thank you.
And the way excited delirium was being used in the United States was, by definition, the absence of an underlying physical cause.
Thank you. And then in your conclusions in 2015, which we can see at the bottom of page 6, you say that at present the term ED might imply that an acute behavioural disturbance can, in and of itself, be the main cause of death, even in the absence of an underlying demonstrable organic cause. However, it's debatable whether ED is defined clinically and pathologically can be conclusively regarded as the main cause of death, as opposed to the cardiotoxic effects of psychostimulants and or aspects of the restraint procedure itself.
Yes.
Thank you. And that was your article from 2015 at that time.
Yes.
And then you've explained to us that you then wrote an article which was published in 2022 alongside Terry McGuinness.
Yes.
And if we
Terry McGuinness is the senior author. He's a barrister with an interest in inquests and the coronial process. So he was a senior author. We've been colleagues and friends for some years because of our shared interest in the question of excited delirium.
And is that how you came to write an article together?
Yes. Yeah.
And we'll have that on the screen here in the room, WIT 00018. And you provided a copy of this article to the inquiry, which the chair will be able to read in detail. But this was published last year and is entitled Excited Delirium, Acute Behavioural Disturbance, Death and Diagnosis.
Yes.
And essentially, I think earlier you explained that this goes through the history of the development of excited delirium as it's become known. Is that correct?
Yes, that's correct.
And from the abstract on page 1, do we see that you talk about the situation in the 1980s and the traditional Hippocratic term, and how excited delirium was transplanted from the bedsides of febrile, agitated and disoriented patients to the streets of Miami, and it related to the difficulties that they experienced in America with cocaine use.
That's right. And in particular, the phenomena of people who'd taken a very powerful form of cocaine, crack cocaine, who died, who behaved violently in public places, who were restrained, who died. And the important thing is, in terms of diagnosis or cause of death, the serum levels, the blood levels of cocaine were only one-tenth of the lethal dose of cocaine. So it was difficult to account for the deaths in terms of cocaine itself.
And you say in the abstract, over the course of the next few decades, excited delirium might be applied to virtually any highly agitated person behaving violently in a public place and who subsequently died in custody while being restrained or shortly afterwards. Expert witnesses, mainly forensic pathologists, testified that the deceased's death was probably inevitable given the perilous nature of excited delirium, even though this diagnostic entity lacked any consistent neuropathological basis and depended entirely on observed behaviour. And was that for the forensic pathologists in the US who were giving evidence?
That's right. And in the United States, a book on excited delirium by a husband and wife team, the Mayos, in a book that was actually dedicated to law enforcement officers who'd been accused of causing death of restrained individuals. This became a handbook, was distributed as free copies to police forces where there was a death in custody. And this became a widely quoted text to account for deaths in custody. So rather than restraint as a cause of death, excited delirium was invoked.
And who were the Mayos? What job did they do?
Vincent Mayo in Texas, I think he was a forensic pathologist. and his wife was a forensic nurse. There's just one edition of the book that came out in about 2006.
So the use of that book was in relation to pathologists, not psychiatrists.
Absolutely. It was used by pathologists and by lawyers in cases where there were complaints about restraint, about deaths in custody.
And as part of the introduction of this article from 2022, you talk about a recent example, well-known example of where this has arisen, in the trial of Officer Derek Chauvin for the murder of George Floyd. And we know he was convicted of murder in June 2021.
Yes.
Can you help the chair understand where excited delirium as a concept had got to by the stage of the George Floyd death?
Yes. Well, I think it's generally agreed that George Floyd died from what might be called a suffocation, using a lay term. And a pathologist giving evidence, the trial of Officer Chauvin suggested that he died of excited delirium rather than from restraint.
And that was obviously rejected by the jury in that trial.
Yes. Yes.
And since that trial, have attitudes changed in America to the concept of excited delirium?
Yes. Well, the American Medical Association has never recognized the concept. The American College of Emergency Physicians, which had recognized it, has reviewed the concept and has changed the name. There have been other changes in this country. For example, the Royal College of Pathologists has banned the use of the term excited delirium. And the Royal College of Emergency Physicians, in its 2016 handbook, had within the title acute behavioral disturbance / excited delirium, and in the 2022 edition they've dropped the initials for excited delirium. So overall there's been a move away from it.
And was that actually at the Royal College of Psychiatrists in the UK?
Well, has never recognized it in the first place. And most importantly, I think the Angelini report said the term should not be used. And following the death of Roger Sylvester, I think the Metropolitan Police, or a coroner around about that time, recommended that the term should not be used. I think that was in 2004.
Well, I'm going to come to those things because you happily mention a number of these in your article from last year. Can we maybe, looking for me at page 2, I see that you say, paragraph 3 towards the bottom, whilst the US National Association of Medical Examiners and the American College of Emergency Physicians consider excited delirium to be a mental health condition, it's not recognised by the American Medical Association, the American Psychiatric Association, or the World Health Organization, and nor is it to be found in the DSM.
Yep.
And you go on to explain that a diagnostic entity requires a standardized definition, a specific diagnostic test, and a unique pathophysiological mechanism with a consistent morbid anatomical basis or a specific etiology. And by contrast, excited delirium has been defined mainly on the basis of subjective descriptions of severely agitated behaviour.
Yes.
And
yes, that's really what I was referring to when I said there was no objective laboratory or post-mortem or other objective evidence to support a diagnosis of excited delirium.
And so is the excited delirium more of a description of different behaviours?
Yes. Yes. Indeed.
And is there anywhere a standard list of the behaviours that could be, a list that could be ticked or classified as coming within?
Well, indeed. Well, the American College of Emergency Physicians produced what they called a white paper, which was an attempt to provide a definition of what they called excited delirium syndrome. And that provided a checklist which was issued to police forces, really to alert them to the possibility that an individual who was apprehended might be in a risky physiological state, and indeed might be at risk of dying from, they actually said, one or more of this cluster of behaviors. So there were roughly, from memory, something like 10 possible features. But in practice, the presence of just one of them was sufficient to provide a diagnosis of excited delirium syndrome.
Now, in your article, you also mention the situation with British psychiatrists, and we've briefly talked about the Royal College of Psychiatrists, and they've recently issued a position statement in September of last year about acute behavioural disturbance and excited delirium.
Yes.
And are you... Sorry?
Yeah. I was on the committee that discussed this over several months and produced this paper. First of all, we rejected out of hand excited delirium for the reasons that we've been discussing and that are really enumerated in the two papers that I've written. The second one with Terry McGuinness. The more controversial term is acute behavioral disturbance. And that term's been adopted mainly by emergency physicians and by the emergency services to describe what used to be called excited delirium. Now, from the college point of view, we feel that's too restrictive an interpretation of the term acute behavioral disturbance. This may sound a bit semantic or pedantic, but what we especially wanted to draw professionals' attention to and the emergency services' attention to was that there's a spectrum of disorders with a wide range of behavioral presentations. with a wide range of underlying causes. And at the most severe end is what the emergency physicians will see, where a person might be in a very severe physiologically disturbed state. And those are people who, quite rightly, should be in the A&D departments of hospitals. What has been overlooked, we felt, was at the other end of the spectrum, if you like, the non-physiological end of the spectrum, is people who are very upset or agitated or distressed generally by bad news or an unpleasant personal or domestic or family or professional situation, who might be seen in public, who are distressed, crying, weeping, possibly falling to the ground, etc., who are not physiologically disturbed, who do not need to be taken to A&E, but who do need an approach which is based on what we were talking about earlier when we talked about de-escalation. What they need is a friendly person to listen to them, to reassure them, and to sort of, yes, to provide reassurance. And you don't actually need generally a professional to help. Neighbors might help in that situation, or a general practitioner might help. It's not an extreme physical emergency such as the emergency physicians see at hospital. And that's really one of the most important messages from our report, is to draw attention to this spectrum of presentations which the term acute behavioral disturbance will cover.
All right, I'll come back to that in relation to when we get to the end of your article and explore that further. At the moment, can I just touch on your involvement with the Royal College of Psychiatrists? And you've explained that you were on the working group that contributed to the preparation of the position statement in September of last year.
Yes.
And that's WIT 00021. If we can just there's a couple of things I'd like to ask you about in this. Obviously, the chair can read the detailed statement in due course. On pages 3 to 5, do we see an executive summary that was prepared?
Yes.
And it talks about the terms acute behavioural disturbance, ABD, and excited delirium, XD, it describes it, which have been used to describe a situation in which a person is extremely agitated and distressed, usually in a public place, and in such a state of agitation that they may be at risk of a potentially fatal physical health emergency. While physical restraint must always be seen as the last resort, it is thought to significantly increase the likelihood of poor outcomes in this group of people. What was understood by poor outcomes?
Risk of death. So it's recognized that sometimes severely agitated people might need restraint because of violence, but the restraint itself increases the risk of what the term you've referred to, a poor outcome, which means a risk of death.
Right. And it goes on to say it's been argued that XD should be understood as a distinct syndrome with a high likelihood of a fatal outcome without medical intervention. And it describes a clear move in the UK towards ABD as a broader umbrella term for a patient presentation of severe agitation, distress and signs of physiological deterioration of unknown cause. but it notes that neither term, ABD or excited delirium, is recognised in DSM-5 or ICD-11.
That's right.
And they go on to talk about the lack of validated criteria to assess whether someone is experiencing ABD, for example. So there's a lack of criteria even if you use the term ABD.
That's correct.
And the current management guidelines may apply to a significant number of people, including those experiencing a mental health crisis. And they talk about excited delirium having been controversial when used in a way that minimises the role of restraint in understanding why someone has died following the use of force by police or health services, particularly those from ethnic minority backgrounds. The disproportionate use of force against people of colour is well documented across health and criminal justice in the UK. Can you explain a little bit more about those comments that were put in the position statement?
Yes. There is a chapter that deals with discrimination on the basis of the skin color, both certainly within the mental health services and by when it comes to restraint in public places. So the evidence for this was accumulated by Sir Simon Westley, past president of the Royal College of Psychiatrists, in his review of the Mental Health Act. And he found, for example, that there's a highly disproportionate use of a section of the Mental Health Act. This is the English Mental Health Act, section 136, which allows the police to detain a person who they perceive in a public place, who they deem to be suffering from some sort of mental disorder, and take them to what used to be called, or is still called, a place of safety, which was originally either a police station or an A&E department. Now, a police station would not be regarded as a place of safety, and so an A&E department is the appropriate place. So there's an excessive use of Section A of Section 136. When it comes to the mental health service itself, the black people were more likely to be restrained while they were in hospital, more likely to be put into seclusion, more likely to have lengthy admissions in secure units, more likely to be involved in the criminal justice system as well as the mental health system, and less likely to have extended psychological help once they were back in the community. So there's a general view that people of color fare badly within the mental health services in England, and also seem to be discriminated against by the police.
Thank you. And then the Royal College were calling for the need for a robust consensus about how to understand, define and respond to this issue, and to make sure frontline services were supporting and providing the best standard of care, whilst ensuring appropriate scrutiny and accountability in the event of a death. And that seemed to be their desire. And it says that there was extensive consultation by the Royal College with stakeholders, including the police. Is that correct?
That's absolutely correct. And within the definition of so-called excited delirium, there were two terms that were regarded and are regarded as racialized. One is the use of the term superhuman strength as a characteristic of excited delirium or acute behavioral disturbance, superhuman strength, and the other is impervious to pain. And in consultation with the community and other stakeholders, it was felt that those two terms really resonated with the institution of slavery. That's to say, severe measures to control slaves were often justified by the use of the terms, oh, they don't feel pain the way white people do, or we have to control them with chains because they have superhuman strength. And those two expressions appear repeatedly in the definition of excited delirium and indeed of acute behavioral disturbance. And we concluded that this was extremely historically insensitive, and not just historically, but part of racial stereotypes nowadays.
And so did the Royal College recognise that racially stereotypical language was part of the definitions of excited delirium?
Yes, definitely.
Was it also connected to ABD?
Yes, because both of those terms, the imperviousness to pain and the superhuman strength, are used in descriptions of ABD by, for example, the Royal College of Emergency Physicians.
That's the American...
As recently as their 2022 edition.
That's the American Association.
No, sorry, the Royal College of Emergency Physicians.
Oh, sorry. Thank you. And then I think on page 4 of this position statement, the Royal College appears to acknowledge the need for practical guidance for frontline staff who are being asked to respond to incredibly challenging situations. Was there a recognition by the Royal College that these are challenging situations that staff have to deal with?
Absolutely. And ideally, there should be arrangements in which if the emergency services are called to a person who's described as suffering from acute behavioral disturbance, in other words, a person who's very agitated in a public place, then mental health trained personnel should attend at the same time to help to understand what's going on, and very often, I think, take over from ambulance and police.
And were the Royal College also hoping that they can encourage organisations to work together and to achieve a consensus in relation to these?
Absolutely. To my mind, the important consensus regarding the definition of ABD is to recognize milder forms of the condition that do not require emergency hospital treatment, but that do require the sort of human support that I've mentioned a couple of times.
And then on page 5 of this document, the Royal College, still within the executive summary, talk about red flag approach to identifying physical health emergencies in an agitated person, and that would help move away from diagnostic criteria based on controversial literature on excited delirium. And they wouldn't need to resort to what's called a binary concept of ABD. And they criticise the current definitions of ABD as too entangled with contested definitions of excited delirium. And they say excited delirium should never be used. Subjective and potentially racialised diagnostic criteria should be removed. So it appears that the Royal College were concerned about the use of either excited delirium or ABD because of the racialised diagnostic criteria.
Yes, those were the superhuman strength and the lack of sensitivity to pain, impervious to pain. The college, you mentioned red flags. The red flags, i.e. a warning of the possibility of a truly medical as opposed to a psychological emergency or an emotional emergency. The red flags would be, top of the list would be a high temperature. That is a serious warning sign for physiological deterioration. Another would be non-stop physical activity, ceaseless physical activity.
I'm conscious of the time, Dr. Lipsedge, but I've only got 2 other questions to ask you about this document, and I wonder if we could just finish those now. One relates to what is page 8, the names of the people on the working group. I see your name. I also see the name of a Dr. Derek Tracy and Professor Keith Ricks. And I wonder if you could tell us who they are.
Yes. Well, Dr. Tracy is a very senior psychiatrist who wrote a very important paper in a journal called Advances in Psychiatric Treatment. He wrote it with Dr. Stevenson, who's an emergency physician in Glasgow. And they wanted to draw psychiatrists' attention to what I would call the extreme physiological distress end of ABD. And they describe, in language that psychiatrists will understand, the physiological disturbances that put the patient at risk, ultimately, of cardiac arrest.
I'm hoping to come to that this afternoon.
Right. So, Derek Tracy has also written very important work on novel psychoactive drugs. And Keith Ricks is a very well-known medico-legal authority who's written a great deal, especially on how to write medico-legal reports. But he's also got long-standing interest in this subject of excited delirium. And I've had lots of discussions with him about this. And he regards ABD as an umbrella term, which is a useful context. And he wants to emphasize there can be multiple causes, and he emphasizes also there's a spectrum ranging from the emotional upset to the physiologically distressed.
Thank you. And then the last thing I wanted to ask you about this document is in relation to the annex, which is at the rear. It begins on page 37, and it's a table that is a list of police contact related deaths where either ABD or excited delirium have been referenced as part of IOPC investigations and or inquests since 2005. And if we could look at page 40 of that table, that's page 37. people here can see that. We see that on the 3rd of May 2015, the Royal College took account of Sheku Bayo's death, and it's indicated they were aware that the public inquiry was ongoing. And it also says that Police Federation lawyer has suggested a link with ABD, and the source is given as Scottish Government 2020. I just wondered if you know anything else about that summary, Police Federation lawyer suggested link with ABD.
No, I don't.
We may be able to look into that.
I think since you mentioned the Federation, just very, very briefly, because I know time's running out, I told the inquiry about the reports I've done on deaths in custody over the years. But I'm an honorary fellow of the Faculty of Occupational Medicine. And that means that over the years, I've done a great deal of work with public bodies, public employers, and indeed with British Transport Police, with the Metropolitan Police, with Wiltshire Police, with Surrey Police, dealing with issues of fitness for work, early retirement, and so on. But in addition, since you mentioned the Federation, the request of the Federation and through their lawyers, I've done many, many reports on personal injury sustained by police officers in the course of their duty, especially officers suffering from post-traumatic stress disorder and other psychiatric injuries caused during the course of their work. I just wanted to emphasize that to counterbalance your awareness of the fact that I dealt over the years with deaths in custody.
Thank you. Thank you very much, Dr. Lipsedge.
Dr. Lipsedge, we'll stop there for lunch. Our usual timetable in the afternoon is that we sit between 2 and 3, take a 15-minute break, and then sit between 3:15 and 4:15. So if you're comfortable with that, we'll aim to do that this afternoon.
Yes, sir. Thank you.
Thank you.